And I think the next question, I'll still have you comment and maybe have Dr. Singhi as well, Dr. Marmarels get their opinion. Brain mets, right? So we've talked about brain mets as one of the resistance, localized persistent progression. We didn't talk about it in Dr. Singhi in your talk because your talk was about resistance, but a very common situation where we have a patient with stage 4 diagnosed with brain metastasis. Do they all need radiation? When,
Mm,
how do we decide?
yeah, it's when I first became a radiation oncologist or a resident, the moment you had a brain met, we had to treat it. And unfortunately, back then we were treating with whole brain. What I learned over the years is absolutely we do not have to rush to treat brain mets if they're asymptomatic, small, lacking association with significant peripheral edema, and now even more so in the era of TKIs and immunotherapy that have penetrance. If their lesions are relatively small and patients are asymptomatic, I don't treat them. In fact, we actually have a trial at MSK, and there are probably multiple institutions that are having these trials where patients that have upfront CNS disease, we're randomizing them to upfront SRS versus delayed SRS at the time of either maximal response or progression, and the idea to see if it really matters. But I don't think it's necessary to rush into the treatment.
And Dr. Singhi, Dr. Marmarels, do you agree?
I agree. Yeah, I think it really depends on the biomarker that's identified. We do have a lot of CNS penetrant, highly CNS penetrant targeted therapies that are now available, like osimertinib, for example. So I agree. I really take it into the context of the patient. We talk about the pros and cons of pursuing a local therapy to the brain. So at our institution, we actually have a brain metastases clinic. And so I'll often refer my patients at the time of diagnosis if they have de novo at the time of diagnosis intracranial disease, they'll have that discussion because with every treatment modality does come a potential for adverse events, for side effects, right? And this is more of a journey that patients have with their cancer, not necessarily a sprint. And so we have to think very thoughtfully about how we treat our patients and sort of what they're going to develop from a toxicity standpoint.
Yeah, and the only thing I'll add is I think the key to this type of approach is short interval follow-up. So if you're going to forego radiation, which is really a pretty sure bet that you're able to treat the brain metastasis and wait for the systemic therapy to see if that's going to work, you need to make sure you're doing a brain MRI, in 4 to 8 weeks so that you're not missing disease that might be harming the patient.